Hello and a very warm welcome here from Medel in Innsbruck in headquarters. My name is Severin Fürhapter, and I now have the pleasure to introduce you to the first Experts Online session of the new year 2022. The topic of the session will be best practice for single-sided deafness, ADHEAR, BONEBRIDGE or Cochlea-Implantat.
Cochlear.
At the beginning, I have a few housekeeping rules for you. So please name yourself, like with the name, the organization and the country. You can do so by clicking on your name in the participants panel and then click on more and rename. We would like to avoid any background noise so that all participants can hear perfectly. So please mute your microphone if you do not speak, and also don't forget to mute your phone. For a stable internet connection on your side, we recommend to close all other programs on your device. Your comments and questions are very welcome. Please put all your questions in the chat. There will be a long questions and answer session after the talks. During this next hour, we also have the possibility for English captioning. You can activate the captioning by clicking on the button at the bottom of the screen. Before we start with the talks, I would like to ask you a question with Mentimeter. So please take your phone or take the QR code and go to www.menti.com. Use the code 3597-2581. I will give you a few seconds to enter the code and enter the web page. I'd say we give it a trial. What is your profession? So we have quite some surgeons in the audience, but also audiologists, audiological scientists, audiology physicians, pediatric audiologists. We also have some doctors. Now the main audience has switched to audiologists, also in several languages. We have ENTs. Yeah, it's a very interesting group that we have here. Thank you very much for giving me your feedback. The topic that we have today is single-sided sensorineural deafness. So in this next hour, we will only talk about sensorineural single-sided deafness. This is defined in the affected ear as having bone conduction thresholds that are severe to profound. And on the contralateral ear, we need to distinguish either having single-sided deafness, meaning that air and bone conduction are normal. And in a second group of asymmetric hearing loss, we speak about persons having a mild to moderate hearing loss. And with this, I can now introduce the speakers. I'm very happy that I can introduce two experts in the field of single-sided deafness. Professor Paul van de Heyning is Professor Emeritus of ENT and Head and Neck Surgery at the Antwerp University Hospital and University of Antwerp, where he is still actively linked as a consultant. He has served as chairman and also as dean of the faculty. He was a founding member, former chairman, and is now vice chairman of the hearing group. His research focuses mainly on inner ear pathology and cochlear implantation. In particular, with his team, he developed the application of cochlear implantation in single-sided deafness and tinnitus. And I'm also very happy to have a second expert speaker in the field, Professor Piotr Skarżyński. He's the Director of Science and Development at the Institute of Sensory Organs in Kajetani and Deputy Head of the Department of Teleaudiology and Screening at the Institute of Physiology and Pathology of Hearing in Warsaw. His scientific activity manifests in a dozen of nationally and internationally funded research projects, as well as in patent applications and active commitment to numerous scientific societies at both national and international level. He's a vice president of the hearing group. Welcome to both of you. And since we have a very packed program, I would like to ask Professor Paul van de Heyning to give us his first presentation. It will be about cochlear implant versus CROS versus bone conduction devices.
Hello, everyone. Thank you, Severin, for this nice introduction. And I start with setting the scene on the approach for single-sided deafness and asymmetric hearing loss. First, I go back to the definitions. We all agreed upon these definitions already some time ago. It was published several times. There is no real discussion about it anymore. Single side deafness means that in the poorer ear, the pure tone average is 70 decibels or worse. And in the better ear, the hearing should be better or equal to 30 decibels. When we speak about asymmetric hearing loss, again, the poorer ear is 70 decibels or worse. But in the better ear, the hearing is between 30 and 55 decibels, with an inter-oral threshold gap of at least 15 decibels. It is quite common in acquired single-side deafness, the estimates of the incidence is about 100 per million adults per year. If we consider and compare with bilateral hearing loss, at this moment, countries where there's a lot of cochlear implantation, they do about 30 cochlear implantations per million adults per year. Here we have an incidence of 100 million adults per year, and important, 40% of these people from acquired single-side deafness also develop very disturbing tinnitus. When we look at the congenital single-side deafness, it is estimated that about a little bit less than 1 out of 1,000 birds has a single-side deafness or hearing loss, and about a third of these children have also inner ear abnormalities. We got aware, due to a lot of studies, on the handicap that is provoked by the single-side deafness. It is on the test clear that it provokes a decreased speech in noise recognition. There is a loss of sound localization. There is an increase in listening efforts, and we see in children that often they have a delay in their scholar development. And of course, there is a loss of health-related quality of life, like, for instance, the deafferentiation tinnitus, as already mentioned, but also the fear for noisy places, busy places, avoidance from professional and social reunions, and of course, the grief of losing your soundscape, and of course, also these attention and concentration difficulties. But we are still surprised that about 50% of the patients up to now that we provided with solutions did not seek for such a solution and ended up with no specific therapy, half of the patients. What are the solutions? Well, the oldest solution is the CROS hearing aid, the contralateral rerouting of signal. The patients are wearing a hearing aid in the better ear, and the microphone is at the poorer ear, and the sound is transmitted whether with a wire or wireless nowadays. And so it's quite useful for people that already are wearing a hearing aid when they have an asymmetric hearing loss and a moderate hearing loss at the better ear. The second solution came already also more than 20 years ago with bone conduction devices. In the bone conduction devices, the signal is transformed to micro vibration, and these micro vibrations are transmitted by the skull, but also by the liquor cerebrospinalis to the opposite ear. And so with the better ear, you hear the sound that is, or the micro vibrations that are foreseen from the other side. And with the different types of these bone conduction devices, with the ones that with a non-implantable solution, like with the ADHEAR, with the solution with a passive transcutaneous solution like the ATTRACT, with the active transcutaneous solution like the BONEBRIDGE, and then of course we've also the percutaneous solutions like BARA and PONTO. And then came the breakthrough. The breakthrough in this field is cochlear implantation. I performed the first one in 2002. We published on it in 2008. Now we have a CE mark 10 years later for this indication, and also an approval from the FDA that indeed cochlear implantation is a solution for cochlear implantation, that it is not experimental anymore. How do we handle when a patient is coming to our consultation with a single-side deafness? After, of course, screening, diagnostics, then patients get these 3 opportunities offered. And we start first by offering them a trial with a CROS system, and then we offer them afterwards with a bone conduction system, or vice versa, a bone conduction first and then the CROS system. Then we inform the patients on the possibilities of cochlear implantation. Maybe we bring them into contact with patients that had already a cochlear implantation. And we also, in the large discussion we had and published it on the minimal outcome measures, that it was necessary to measure aided and unaided pure tone audiometry, speech perception in noise, localization, and the quality of life measures, the impact of the hearing, also the more generic ones like health utility and the tinnitus questionnaire. And everyone was convinced that also the use of the device, the time of use of the device, is an important outcome, because that proves whether patients have really benefit of it, whether they're really actually using it. Using this protocol, recently there are 2 important studies. And the first one is from Würzburg, from Anja Kurz, and the other one is a French inter-university study from Marx. And the outcome was that in the study of Würzburg, about 1/3 of the patients afterwards opted for a cochlear implantation. This was the same also in the French study. 1/3 of the patients at the end opted for a cochlear implantation. There's a big difference from the other possibilities. In the French study, half of the patients choose for a CROS system, but these were mainly patients with asymmetric hearing loss and not as much as single-side deafness. Whereas in the German study, it were more single-side deafness patients, and about 20% opted for the bone conduction. At the end, in the German study, nearly half of them still did not opt for any of these therapeutical solutions, whereas in the French study, it was only the minority that did not opt for one or another solution. So this is the start, and I give the word back to Severin. Thank you for looking at these possibilities.
Professor van der Heyning.
Yes.
With this, I would like to hand over to Professor Piotr Skarżyński, and his talk will be about his experience with cochlear implant in acquired single-sided deafness.
Yes, I think you can see my presentation.
Yes.
Yeah, okay. I would like to thank you for the invitation on behalf of the team, because that result and our experience is based on surgical work from my father, me, and some other colleagues, and as well as a team from audiology like Anita Obryska, Professor Lawrence, and Dr. Walkowiak. So we do it together. It's extremely important in single-side deafness. I could talk hours about single-side deafness, especially with bone conductive devices, but that topic is cochlear implant in acquired, and why it's important today. There is a lot of numbers of patients who are after COVID single-side deafness. Really, I have a lot of such patients, and also some other colleagues reported that this is potential quite large group. And that's what is important, that we need to differentiate. Professor van den Heyning really very nice underlined the difference. SSD, so single-side deafness, what it means. Super good hearing in one ear and no hearing on second ear. And that's what is asymmetric hearing loss, what is other. So this is a lot of different, hearing. It means that the good ear is not the really good ear in the hearing. And it means that that ear is not good for bone conductive device. It's one of the common mistakes at the examination room. So I would like to underline before talking about CI, if you have any doubt about the good ear, if this is really good ear, in my opinion, below 20 even is not good. Don't offer bone conductive device, because today would be okay, but in 5 years, 6 years, it would be not enough okay. So then we need to go for CI. Patients which we have results after fitting, we have 557. patients, even the 87 years old, mean duration of the deafness was 16 years. It means that earlier the patients were on the waiting list. The reimbursement was not so common. It was not easy, so we cannot offer it for everybody. And they were really waiting for a long time. They tried different options, but they were not successful. And that hearing loss, it was SSD and asymmetric hearing loss is like that. So that really SSD doesn't happen so often in elderly population and on seniors. Really on high frequencies, quite often that hearing is not good enough. And what I would like to underline in that slide, in that adults which we have with that single side deafness, we have congenital, which is very rare and not easy to treat if the patient is after 40 years old, but we really have the patient really after 30 years, after the 30 years old, there was implantation in congenital. There are some effects, but it's really not easy. And really we need to be careful with that. The best patient, the best results are with sudden hearing loss. And then we know that it's not good effective, there is oxygen therapy, steroids, intravenous, etc. And another important is progressive, and progressive could be from different issues. For example, sometimes it happens that it's enlarged vestibular aqueduct in single side deafness. Only one side is not so common, but it happens. And then it could be good, bad. And after 10 years, 15, 20 years, it could be not enough good, and then we offer implantation. But that patients are really good, and then they are quite often motivated. They want to wear something, and they are quite often, people which are relatively young. So there is a good group which try to understand what we could present them. The method of examination, it could redundancy, head shadow effect, squelch effect, and sound localization. That's what we could, present, how it could work. In that two presentations, which I will have, they have different methods for assessment. Monosyllabic word test will be for children, older than 10 years old. It's not easy to examine them below. So we offer for between 3 and 10 years old, which is extremely difficult group for examination for SSD. With auditor adaptive speech test. There is different speaker configuration, and really if you read publication about that, different authors, they have different speakers configuration. So really please look on that, how it works for your better imagination, how we measure, and with other colleagues on the field. This method of localization in our audiological department, how we try to analyze the mistake in the in localization, how they look for that, and the results for monosyllabic test in that group, in adults group. So you can see that monosyllabic test, there is statistical significance with implant and without implant. It means that higher is better. So you can see that all categories is better. So there is no doubt. If you have patients who are coming to us because sometimes they, feel enough good, they don't want to come. Sound localization test also, we can see that it works. And what is important with SSD patient, we need to meet with them more often. It's not one fitting and go out. Quite often we need to play a little bit that with fitting. We need to, make more amplification, less amplification. We need to differentiate channels, and you can see, it's more complicated slide, but you can see with asymmetric and SSD cases, how it looks with redundancy in numbers, in how is mean, how is standard deviation. And you can see, I would like to tell, in all cases, there is effect. So we see the effects if there is potential for that patient to have implant, and there is the, counseling time, which we discuss later in discussion with Professor Van den Heyning and with others, how we do this. And also there is difference between prelingual and postlingual. So you can see that acquired, what is the topic of that exactly presentation, that the postlingual cases, they are better than prelingual, that we can obtain much better in terms of a lot of parameters. We did some publications on that, and also I would like to underline what is crucial. In many cases, like in Belgium, one of the conditions is there is the tinnitus. So we need to examine tinnitus to have reimbursement to be in that better, side of the moon. In Poland, it could not be tinnitus, but we analyzed also that in ADHEAR, if there is lower, it means there is better. So patients without the tinnitus, they have quite sometimes different results than the patient with tinnitus. So we also need to analyze other factors, not only hearing, but the tinnitus, also the depression scale, on other issue, how it works, and we need to talk about them, how they would like to use their hearing, what will be important for that. There is several factors, which I hope we will discuss later, when, why, and which implant we use in terms of the SSD. Extremely important is you must have CT scan. You need to check it if there is no ossification. Ossification is not contraindication for implantation, but we need to know what we will meet during the surgery. Which electrode we should choose, MRI, of course, in asymmetric hearing loss, and the hearing aid trial. There will be a lot of discussion. I don't like to make the CI in the patient without any experience with other solution. For example, because I talk simple example. If something will be broken for the hearing aid, it's much cheaper with the implant. And if somebody have no respect for the implant, also have no respect to the hearing aid. So this is not like on off. We need to show that there will be something on their ear. They will wear something and they will get acquainted with knowledge with all that audiological word. The rest we'll discuss later during our discussion. Thank you very much.
Thank you very much, Professor Skarżyński. We will now switch again back to Professor van der Heyning, and his talk will be about cochlear implant versus bone conduction devices in acquired single-sided deafness.
Yeah, again, I will go. I'm not using my presentation mode because for one or another reason, I can see it on my screen, but it does not come to your screen apparently. So the first reason here is to compare or to give you a number of elements, how we can compare these different solutions and what we can tell to our patients. So we'll go through to the tinnitus differences, speech recognition differences, directionality, quality of life, and the use of the implants. But it is not the meaning here that at the end, that I will make an end conclusion. The fact is that for each patient, we have to choose the right solution. First, we go to tinnitus. Piotr has also already clearly shown that tinnitus is going down. When we see patients that present themselves with a high level of tinnitus here on a visual analog scale in our first group, 8 on 10, very high, and we see that with a very steep reduction of the tinnitus loudness and also the tinnitus burden in these patients to about 1/3 of the initial value. Also at a long time here is a mean of 10 years with now patients that we follow more than 50 years, and the result stays the same as long, of course, that the cochlear implant is activated. Once they deactivate the cochlear implant and the tinnitus comes back to its original value. Also, when the patient is presenting with a low level of tinnitus, this study from McDillan from UNC in the States, you see that there is a clear decrease of tinnitus in these patients. I have to warn everyone to be sure that the patient has not a severe depression. A severe depression is a contraindication of cochlear implantation. First, the psychiatrist has to do his work, and you should not operate patients with a severe depression. We also analyzed data of tinnitus with patients with bone conduction device. This is the loudness of tinnitus without the bone conduction, and with the bone conduction, you see, in fact, that there is no improvement. There's only one study showing that there is a slight improvement in case that there are low levels of tinnitus, but on the average, we found out that when we were giving patients a BAHA trial, bone conduction trial, when they have high levels of tinnitus, then none of the patients, or nearly none of the patients, would opt afterwards for a bone conduction or a CROS system. All the patients that opted for a bone conduction or a CROS had rather lower levels of tinnitus. So this is one element that we take into consideration when we offer the different possibilities and discuss them to the patients. Is the tinnitus, when there's high levels of tinnitus due to the hearing loss, then for me, cochlear implantation is the first choice. Now the hearing. The hearing, quite some publications have shown that by doing cochlear implantation in the deaf ear, that the deaf ear indeed provides good speech understanding on itself. As well, the thresholds, speech in quiet and speech in noise, they all improve by doing cochlear implantation also in a single-side deafness, although it is dependent on the etiology of the deafness. Some etiologies are less good, and also the works group with Anja Cruz have shown that if the reason are measles or inflammation, the outcome is less good than when it is, for instance, as just mentioned by idiopathic sensorineural hearing loss. I'm not going into the results of cochlear implantation in single-side deafness. They have been very well brought by Professor Skarżyński. The main effect is still the head shadow effect when using it, and it is quite remarkable. You get it already after a few months, this effect with very significant improvement, speech to noise ratio in cochlear implantation. When we now compare it with other devices like the bone conduction device, this is a Ph.D. thesis that was done in our institution already 10 years ago. We could not find any summation effect, no squelch effect, but with the bone conduction, there was a clear head shadow, positive head shadow effect. And a recent study published by the Utrecht group in the Netherlands showed, compared the different possibilities. Cochlear implantation, and this now I show you in this publication, the head shadow effect. Cochlear implantation had the most pronounced effect in improvement already after 3 months and 6 months. Bone conduction and CROS also improved significantly, but not as good as the cochlear implant. And patients that had chosen or were in the group of no treatment, well, of course, they stayed similar. Also, by time, they did not improve speech understanding in this group. So this is very well consideration. What are the benefits of bone conduction? There is another point. When you have, for instance, in this case, a deaf ear at the left side, you have speech in front, but there is disturbing noise at the deaf side or at both sides, like here, and you consider this speech in noise ratio level for patients when they are unaided. When you add BAHA to it, then the speech understanding becomes worse. The BAHA brings disturbing noise to the good ear, whereas if you do cochlear implantation, this deleterious effect is not present. With a cochlear implantation, you have not this disturbing effect of noise at the implant site, which makes that the circumstances in which a patient will use this solution, CROS, BAHA, or cochlear implantation, are also of importance in choosing the right option for a particular patient. We assessed also the directionality, and also shown by Prof. Skarżyński. This is the value for a patient, for normal hearing person. Patients with single-side deafness have no directionality. This blue bar is the limit beyond which there is no directionality. By activating it, we see an improvement of directionality. It is not becoming normal, but directionality is clearly better. When we compare this with the other means, and this is a study from Kurtz, you see that CROS is not offering an improvement in directionality. Bone conduction device is not offering an improvement in directionality, although there is one study that gives some indication of a limited improvement of directionality, whereas cochlear implantation at 6 months and at 12 months clearly show an improvement. Once again, depending on the etiology and the amount of time that the patient is wearing the cochlear implant, there's a lot of variation, and the initial etiology is of importance. Are patients using these cochlear implants? Well, our experience that patients with cochlear implantation and that had also a benefit from this tinnitus reduction, also after 10 years, are using the cochlear implant every day, all the day, from the moment that they open their eyes until they go asleep. This is the category of our CI patients that are most keen to use their cochlear implant. When we look now at the patients with bone conduction device, we also did an analysis of patients using their bone conduction device. It were BAHAs at that time for up to over 10 years. We see that even after 10 years, a good amount of the patients are still using their cochlear implant every day. And overall, with more than 90% of users after 10 years, but they didn't use it all day long. When we compare also the different types of bone conduction, and here we compared the active bone conduction with BONEBRIDGE, with the passive BAHA and attract, we saw that our patients with BONEBRIDGE were using their cochlear implant every day twice as long as those using the passive device. So there are a lot of variations also in the bone conduction device, and that's an element also in the choice the patient has to make. We come now also at the last point of comparison. It's on the quality of life. I show here the SSQ, the ability to hear. At the right side is the study from UNC in the States, at Chapel Hill, with the SSQ questionnaire. And you see a steep improvement of the hearing and perceiving abilities, even from the first month of use, and that as well in speech, spatial as quality subdivisions of this questionnaire. When we come back to the Utrecht study, again, here we have cochlear implant, bone conduction, CROS, and no treatment. You see patients with no treatment stay at that level, do not improve over time, do not adapt to it, whereas the cochlear implant outperforms the other possibilities, but there is a clear also improvement in the SSQ as well for the bone conduction as for the CROS system in these patients. A study of Wilsburg that I mentioned already assessed the quality of life with the Nijmegen cochlear implant questionnaire, and they found with no solution, no improvement on the Nijmegen questionnaire over time, but with CI they had the largest improvement, but also significant improvements with the bone conduction and the CROS devices. I give the word back to Severin to go on with the different aspects of single-site deafness.
Thank you very much, Professor van der Heyning. And now there is one aspect that we would like to address, and I would like to ask Professor Skarżyński to talk about cochlear implant in congenital single-sided deafness.
Okay, so we had very nice presentation regarding a lot of audiological outcomes, and this is really crucial for, I think, significant part of our recipients today during that expert online meeting. And I would like to state on one thing in terms of the children. The dilemma which we have with congenital hearing loss, at first, if there is really a single-side deafness, we have during the screening the issue. So something is going wrong. Quite often that decision about implantation is a little bit delayed. So you can see that that peak is 2 seconds, 3rd-year-old when we make implantation. Sometimes the parents are not convinced, they don't want, they try to use some other solution. And you can see the another wave is when they are in school and we can see there is not enough good, marks in the school. There is not other issue, they are equal with other children. So in my opinion, if you have fully deafness and we have normal ear and is fully diagnosed in MRI, in the CT, the CI is the solution. Of course, there's always a risk that there will be not enough good results. It could be neuropathy, but if there is no contraindication from anatomical point of view, the CI is a good solution. If there is any doubts, like the cochlea is not normal, there is a risk, especially facial nerve. Quite often, this is the issue. We have facial nerve abnormal position, so there is the risk to do. Then we could go for some other solution. And when we see that material, you can see the majority, there is the SSD. So almost 70% of the children with CI, they are SSD. There's not asymmetric hearing loss as much, so there's only 32%. And that congenital and sudden, it could happen also that sudden means quite often there is a viral infection. So as I observe personally, that sudden hearing loss is directly connected with some viral infections, which could happen. And this is the also issue to know how to play with that. Also, we examine tinnitus with that, but it's not so easy to talk about tinnitus with children. There is a lot of discussion about that. We really do this, but on the preoperative examination, but there is not important role in the 1, 2, 3, 4 years old children because we cannot ask them about the tinnitus. It's only possible in the elderly. So that's why we divided, especially with Anita, we divided that group for 2 group of children. Is older children. There are 11 children with CI between 6 and 14 years old. So there is a period when they are They were in the school, they had some issues with the marks, they wanted to do something better, and they quite often were after some other solution. Age of examination was between 10 and 18, and they were quite experienced. So they were some years experience with the CI. And you can see that results are also very good, except on squelch effect. The redundancy and head shadow, they are statistically significant, they are better. And the sound localization also was much better, but what was not easy to do it with them. Younger children, there is a group which now we can say that there is almost no queue for them in our center with the reimbursement issue. If we have congenital single-side deafness and there we see that there's chance for the CI, we try to do it as fast as possible as for other children. So that 8 children which I will present you with quite also experience with 1.5 year experience is relatively a good number. You can see that results in ASSD are not as easy to obtain like others. With head shadow effect, we obtain statistically significant better results. But we would like to base more on results which will be later. That's what I would like to underline from more practical issue in your clinical practice. We don't offer CROS hearing aids routinely till 3 or 6 years old. So we offer CROS when they go to school or if they have, quite intensive kindergarten. So this is the issue which I would like to not recommend to do this, especially in the first or second years of life. We can do powerful BTE. Of course, if there is some residual hearing, the child will have something on the ear, it will be something noisy, we see how it will be reaction. So we get acquainted the child with doing something and with parents. CT and MRI is not also easy because, in pandemic time, there is the limitation of MRI in anesthesia. So this is it from practically, maybe in other countries not as much, but some procedures disappeared from the common access. So the CT is easier because it's faster, we can keep the child. If MRI is more difficult, and if there is no contraindication, would like to do it as fast as possible. There is very nice publication in NAME. If we have no good hearing, how our brain will change. So that all work, especially efforts from Professor van den Heyning to presenting how it will be difficult to train our brain after that, is crucial that we need to do something. So this is what I wanted to show you in that short presentation, and I open for the discussion during the questions from your side, from professor's side, about a practical issue with SSD. Thank you very much.
Thank you very much, Professor Skarżyński. I would now like to ask you another question on Mentimeter. Please take again your phones. And I would like to ask you, in which country are you currently located? So we have guests from Libya, from Poland. I saw in the participant list that we also have people from other countries. I guess we will give you a few more minutes. We have, of course, Austria. In the chat, I see that we have a professional from South Africa. Welcome. Welcome to Germany. The dominating country at the moment is Poland. Hello, India. Hello, the United States. Hola, España.
Guadalupe.
Hello, Sri Lanka. Hello, Switzerland. In order to save time, I think we need to stop the Mentimeter now. Thank you very much. And this now opens the questions and answer session. I see that we already have questions in the chat. There are no questions. So thank you all very much now for the presentations. And I see that there are a lot of options for single-sided deafness. My first question to the two panelists would be, how do we approach a patient with acquired single-sided deafness? Maybe Professor Skarżyński, you have an opinion on the topic?
Yeah, so I can answer, and after that, if we have acquired single-sided deafness, first, of course, is meticulous diagnosis. MRI, CT, we need to have, information about the infections, about the issues in the middle ear, to analyze radiologically that, to see if there was no other history. And quite often, this is very important information which followed me to learn more radiology. You need to have good cooperation with radiologists, or you need to learn radiology to know what is the really CT scan. Quite often we received, especially from some other hospitals, okay, the brain is symmetric, it's nice, the bone is nice, but there is a lot of small issues which could happen. LVAS is a large vestibular aqueduct is one of the syndrome. There are some other issues. Another is to see if there is not ossification. In viral infection is going quite often. And also if we see that there is from the round window 1 millimeter, for example, too wide area, it means that it could happen something earlier. We need to exclude also some other issue which could be with sudden hearing loss, like, you know, potential conflict, vascular conflict in the internal canal. It could be the, of course, neurinoma, which we need to exclude. So there is a lot of issues to exclude. Then is to make the proper therapy. It was sudden, we have the proper, you know, treatment of sudden hearing loss. Then is to observe and to put non-implantable solution. Powerful BTE, if there is no effect, probably there will be no effect. It's one of option. CROS is a second option, which quite often is not accepted, but acceptance level increased when there was wireless CROS is much better. And then prepare the patient for the CI. I honestly like, if there is no ossification, to make implantation no later than 1 year after, you know, sudden hearing loss, when I know how was the fluctuation of the hearing, to do the proper electrode. I like Flex 28, but if I feel resistant, and this is what I would like to tell, quite often in single side deafness there is some resistance. There are some spikes after sudden hearing loss. And it could be much more, you know, force you need to use to do the insertion. So you need to make a little bit more posterior tympanotomy, to have a little bit more space to do the proper insertion and to do the implantation. But really the counseling, not only with us, a surgeon, with psychologists, with engineers, that there is not on-off procedure. You need to come several times. It's really optimal to be good user. I think we all remember in Germany how many non-users were at the beginning, and there was discussion which now is essential, because we need to know how to treat them, to do the music onto your processor, to do the nice sounds, to change the fitting, to have potential users which need to train their brain.
Thank you very much. I see a very interesting question in the chat, or several ones. Mr. Bogdanov asks, in which cases would you advise for a CROS or bone conduction crossover CI in single-sided deafness, considering that audiological results are obviously better with CI?
With BC CROS, no. Bone conductive CROS, you know, ADHEAR is a very good solution, but there is a lot of issues with the skin. There is an issue with the weight of the patient, the subcutaneous tissue, and that the bone conductive CROS in hearing case as a trial, you know, as a trial to do is very good. Implants, I will the only implant with bone conductive in patient with very good hearing in the ipsilateral ear, no more than 20, with observation how is the progression in high frequencies, and really with some abnormalities in the ear. So when there is, for example, facial, which I don't want to risk, or there is, I don't know, sigmoidal sinus with 2 millimeter space between posterior wall of the, but it's very rare. The BC in CROS was fashion and trendy 5 years ago. It's true, there is a lot of patients. It was solution when the CI was not accessible. But today, if we can, we do CI. If we cannot from anatomical reason, then we do the BC. So it's how we do 200 BC bone conductive device per year. Maybe CROS will be 5%, maybe 3% of them.
Thank you very much. Professor van der Heyning, I saw in the chat another question on tinnitus. How is tinnitus and CI affecting the sleep?
Well, there is
how does the CI affect sleeping in patients with severe tinnitus?
Yeah, well, of course, we tried to activate the CI also during the night, but that didn't work out. You know, when we deactivate the cochlear implant and the tinnitus comes back, the next day it will be at the same level as before. And then you activate the cochlear implant and the tinnitus goes down. But during the night when the patient is asleep, we cannot activate the cochlear implant. Maybe in the future when we have full implantable systems, maybe we can activate it during the night, but currently this is not possible. The reason for that is twofold. First of all, to reduce the tinnitus, there need to be some noise. So if patients, for instance, now awake during the night to go, for instance, to the bathroom, and they have a loud tinnitus and they put on their cochlear implant or activate the cochlear implant, they also have to make some noise, clapping their hands, say something, otherwise the tinnitus is not going down. So you need to have noise, which is of course not the aim to have noise during the night. And the second point is patients wearing a coil during more than 24 hours gives sensitivity at the place of the coil, so your skin is also to recuperate from the pressure of the magnet. But overall, patients had an improved sleep because due to this eye, they had better control over their tinnitus. The fact that they knew that they could control it improved the system. At the other hand, many patients were using sleeping medication before the cochlear implant, and many stick to it and continued using it.
Okay, thank you very much. Professor Skarżyński, with the topic of congenital single-sided deafness and CI, I guess you hit an interesting point, and this needs more investigation. I saw several questions in the chat regarding congenital SSD. There was a parent that was talking that the daughter was 5 years old, but the speech understanding was quite good and congenital single-sided deafness. What would you suggest to her?
Again, I don't see that question from the chat. I see only question from Hamid Reza. Okay, I'll answer for Hamid Reza and we go back to your Hamid Reza Moyalal.
I think there's also an interesting question on the rate of, please answer the question from Hamid Reza.
This
on hearing nerve deficiency.
Hearing nerve deficiency, we do MRI and quite often we have information from radiologists that there is no nerve or absence of nerve, but it's normal canal. Then we do at least 2 times frequency specified ABR, of course, with impedance that we are sure that there is not fluid. If in any of that examination we see any response, for example, on 100 decibels, then we do implantation and quite often there are results. Sometimes it happens even if radiologists they don't see, but we need to obtain. Another is that we need to do the BTE test, and then we see any effects, any results on the BTE hearing aid, we also could go for CI. If not, no. And the question again, 5 years, could you repeat?
Yeah. May I ask the team to go up in the chat a bit, that I can read it out? Yeah. There is a mother from India or a father. My daughter has congenital SSD, but her speech is so good. What do you suggest? She's 5 years old.
Okay. Very good question. If there is 5 years old, quite often till the normal school, they have very good speech understanding. They do well, then develop well. And as I presented, the problem starts in 10, 12 years old. When there is more intensive knowledge from school, they need to collect more information, more noisy situation. And that's why quite often decision which is we do at 6 years old when they go to school, and we do implantation before they go to school, not to have stigma. So for speech development, quite often they do well. In 1 year, we can develop very well. There is issue which starts to be problem when there is some otitis media, and they come to us. And quite often we identify that when they have problem with the 2nd ear, and when there is more often, of course, after adenotomy, the grommets, we could consider CI. I would do the implantation. Why also earlier than later? Because if we will wait longer, the brain will be not lazy, but will be a little bit more problematic with training. So we later need to train much more when they will be older. And the worst age, and this is also information, the worst age for 2 CI in SSD is between 12 and 18 in adolescence. Why? That's why, for example, we don't like to do this in that period, because there are a lot of non-users. And another group of SSD, when I don't like to do the implant, is moms. After moms, that results are worse than with other groups. It's also important. We have vaccination for moms, but it's okay. But some people, when earlier, they have no vaccination.
Okay, thank you very much. You raised an interesting topic. It's the people that become non-users or that actually decide to choose no solution. So, Professor van der Heyning, how could we reduce the patients that now have or choose no solution and come to your office?
There are two different aspects. There are the patients that become non-user, and patients that do not opt for a solution.
Okay, yes.
First, those that are becoming non-users. First of all, if we do this paradigm that I explained and that we were all agree upon, then you have very few non-users. If we see in the CI group and you select well the patients, the number that are not using the cochlear implant after time is quite limited. Those that have tinnitus, I said it already, you'll be absolutely aware that the patient has no severe depression. The people that did not use their cochlear implant anymore in SSD were patients with a severe depression. So that is a no-go. You have to evaluate your patients by your clinical psychologists or psychiatrists to be sure that there is no major depression. That's the main aim. But all the other patients were very well users. Then at the bone conduction side, doing a trial during several weeks with a headband is apparently a very good selection for users. We had also a limited number of non-users in the bone conduction side. Of course, you have a number of patients that had surgical problems at the implant side. With the BONEBRIDGE, this problem is solved. We have nearly no problems with BONEBRIDGE. With the percutaneous system, you have a lot of issues, up to 20–30%. Over time, we'll need some revision or extra care, and in some patients even you have to explant. But doing the trial is a very good way of finding out whether a patient is happy with, for instance, a bone conduction or a cross solution.
Thank you very much, Professor van der Heyning. And this, I think, is a perfect opportunity now to talk about the hearing tool, the counseling tool for single-sided deafness that you developed together with the hearing group. Can you please share your presentation with us?
Well, first of all, first some words about hearing. What is hearing? Hearing is a group of 31 centers. No, that doesn't want to progress. That's hearing is a group of 31 centers. We form a network that have a comprehensive program on cochlear implantation and other auditory implants. I guess with the totality offers an experience with more than 70,000 cochlear implantations worldwide. You see there are centers in Australia and centers in Canada. There are centers in Japan and in China, and centers in Argentina and in Brazil, all over the world. And so we are seeking solutions, best possible solutions for auditory implants. And we do educational work. We work together on innovation, and we want an overall comprehensive solution and advice. And therefore, we publish regularly also guidelines, like the guideline on quality standards on adult cochlear implantation in single-sided deafness. With all the group, we did a number of discussions and came out with a counseling tool. And you see above the web page where you can get access. Everyone can get access to this tool. It's a solution for single-sided deafness. It is discussed by all the members, but it's a special Professor Hagen from Würzburg who had put his shoulders on it to finalize this work on the counseling tool. What is a counseling tool on single-sided deafness? Well, you will find on this page the different solutions. Here, no treatment, and CROS, we come back to that, CROS, bone conduction, and cochlear implant. Each time in yellow-green, you will see the audiological aspects. In dark green, you will see the medical issues, and then in blue, the user aspects. And we address the benefits of it, and we address also the drawbacks of it. For instance, a benefit of no treatment is, of course, no surgery and no stigma. That is self-evident. The drawbacks is that there are also no benefit in this. And when you click on one of these items, you will get also the full reference scientific list that backs up this advice. Here you have the CROS hearing system with the benefits and with the drawbacks. For instance, the drawback, no binaural hearing in the CROS system. When you click on CROS system 8, then you can get the different scientific points. Here, bone conduction system, again, no binaural hearing, but benefit, for instance, effective against head shadow effect. A drawback may be for some of the forms, there is an MRI artifact in some implantable systems, and there is no benefit for tinnitus. So each time you get the improvements. Benefit, for instance, for the bone conduction is that it is proved for scholastic performance. So when you click on that, you get the publications showing this, and you can also go to the different forms that we addressed, like the ADHEAR, the ATTRACT, the bone conduction, the BONEBRIDGE, and the BAR of Ponto, with the different advantages and drawbacks. And so we come also at the Cochlea-Implantat part, also to know what is the advantage or the disadvantage. An advantage is that it will restore binaural hearing. A disadvantage for the patient is that you will need quite a lot of rehabilitation in this program. And also addressing one of the questions, how can we reduce non-users? Well, it's also to emphasize the rehabilitation aspect of this patient. So this is a very powerful tool that all the participants can access immediately and can find out the different elements. And then you can also discuss this with your patient on the different aspects. And the patient, of course, for him or herself, is to feel what is important for a particular patient, what is important for a particular situation. Medical, also audiological, but also from the user's perspective, what is the patient really expecting from this device for him or for her in their particular situation. I come back to a last slide to say what is one of the reasons why some patients are not opting for a solution. And here there's a study showing the speech in noise possibility, lower is better. This is the box and whisker tool for people that are bilateral normal hearing. These are patients with a single side deafness and those with an asymmetric hearing loss. You see, with the asymmetric hearing loss, the hearing is quite poor than, of course, people with bilateral normal hearing. But you see that also in the categories of single side deafness, there's a subset of patients that have quite good hearing performance. And maybe that might be one of the reasons that these patients cope better with a single side deafness situation than others do. And also we know that some of the patients have some directional hearing and also not disturbed, not so much disturbed by their single side deafness. That's maybe one of the reasons. Anyway, we see that there is an important shift now with the cochlear implantation that once they are reimbursed, that this burden gets away and that much more patients are opting positively and get benefit from cochlear implantation in single side deafness.
Conclusion of this session, of this wonderful session. Thank you, Professor van der Heyning, and thank you, Professor Skarżyński, for your nice and very interesting contributions of the state-of-the-art treatments in single-sided deafness. With this, I would like to conclude this Experts Online session and invite you to our next Experts Online session that will take place on 26th of January. The topic will be natural pitch with cochlear implants, and the speakers and presenters will be Margaret Dillon and Tobias Rada. For now, I would like to thank you for your attention and wish you a wonderful remaining or upcoming day. Bye-bye.
Thank you. Bye-bye.
Thank you.